So good day everyone. Today we begin part 1 of our series on inpatient hyperglycemia. It is an often underestimated issue with serious clinical consequences. We will start by defining what inpatient hyperglycemia is and why recognizing it early matters in hospital care. So let's go now to the definition of hospital hyperglycemia. It is any glucose level above 140 milligrams per deciliter and occurs in patients with or without known diabetes. Now next is the classification of hospital hyperglycemia. Number 1, known diabetes, diabetes diagnosed and treated before admission. Number 2, newly diagnosed diabetes, that is hyperglycemia during stay and confirmed after discharge, meaning existing but unrecognized diabetes. Number 3, hospital-related hyperglycemia, that is hyperglycemia during hospital stay and reverts to normal range after discharge or once patient gets well. It is also called stress hyperglycemia. Now, the primary mechanism behind stress-induced hyperglycemia involve the surge of stress-related hormones, especially counterregulatory hormones and inflammatory cytokines released from the injured tissues in critically ill patients. This response is sometimes referred to as CIIH, or it stands for critical illness-induced hyperglycemia, typically observed in those who are moderately to severely ill patient. Now, why does stress hyperglycemia matters? Research have shown that it leads to worse outcome than pre-existing diabetes. Patients with new onset of stress-related hyperglycemia have up to 10 times higher inpatient mortality. And this trend is evident also in ICU setting. Stress-induced hyperglycemia, therefore, is a strong indicator of poor prognosis, often more critical than known diabetes in predicting mortality. This is likely because it reflects the underlying severity of the illness itself. Now, this is the algorithm from the American Endocrine Society guide in the diagnosis of inpatient hyperglycemia based on clinical context. For example, high-risk patients such as those on corticosteroids, total parenteral nutrition, or undergoing major surgery. They should have bedside glucose monitoring for at least 24 to 48 hours. If a hospitalized patient blood glucose exceed 140 milligrams per deciliter, regular monitoring should begin. An A1C test helps determine if the hyperglycemia is stress-related or due to undiagnosed diabetes. If level persists and rise above 180 milligrams per deciliter, treatment should be initiated to reduce complication and improve outcome. That is even more so for those with known diabetes. Now, routine A1C testing offers several clinical benefits. Number 1, it helps evaluate a patient's glycemic control before hospital admission. Number 2, it aids in distinguishing newly diagnosed diabetes from stress-related hyperglycemia. Number 3, it provides insight into expected inpatient glucose pattern and risk of hypoglycemia. And lastly, it supports the development of an appropriate discharge treatment plan. Now, the prevalence of inpatient hyperglycemia in all hospital admission in one study described by Perez et al. Is about 38%, and about one-third of these had no history of diabetes. In the ICU prevalence, the range is from 40 to 60%. 60 in the nice sugar study, and up to one-third may have history of diabetes. So overall, the prevalence of diabetes in hospital is high and still increasing. So now let's look more closely at some individual studies. In 2002, Umperes et al. Collected data from medical and surgical patients in a community hospital using a blood glucose threshold of 126 per deciliter to define hyperglycemia. They found out that 38% of patients had elevated glucose level, 26% with previously diagnosed diabetes, and 12% with newly identified or stress related hyperglycemia. Now, in 2007 study by Kosiborod involving 17,000 patients with acute coronary syndrome, hyperglycemia was defined as a blood glucose level above 140 milligrams per deciliter, consistent with the ADA ACE clinical recommendation at that time. The data showed that approximately 80% of patients with diabetes had blood glucose level exceeding this threshold. Notably, even among those without prior diabetes diagnosis, about 1 in 4 exhibited elevated blood glucose level. And these patients without known diabetes may be exhibiting stress-induced hyperglycemia, a condition that is frequently seen in hospitalized individuals. Now, the impact of hyperglycemia. We know that in-hospital hyperglycemia are common. The question now is, should you care about it? Now, numerous studies show that we should, because in-hospital hyperglycemia adversely affects hospital outcomes compared to patients with normoglycemia. As seen in these slides, with different studies in different settings, patients on total parenteral nutrition, non-cardiac surgery, neuro cases, pediatrics, trauma cases, medical patients, etc., it is associated with increase in hospital mortality and morbidity, such as increase in rate of infection, pneumonia in medical patient, increased risk of wound infection in case of surgical patient, length of stay, and thus hospital costs. So, hospital hyperglycemia is undesirable. Why? Because it is linked to poor adverse outcomes and may occur in individuals who have no prior diagnosis of diabetes, either due to undetected diabetes or stress-related illness. These patients often experience worse than those with known diabetes, highlighting the need for early recognition and management. So many experts advocate for including blood glucose as the sixth vital signs alongside with temperature, pulse, respiration, and blood pressure. And since hyperglycemia frequently occurs among hospitalized patients and is closely associated with poorer clinical outcome, routine monitoring helps detect hidden diabetes or stress-induced hyperglycemia early, allowing timely treatment and better care. So with that, I would like to conclude this presentation. Thank you for your attention. Now that we've highlighted the significance of hyperglycemia in inpatient setting, let's move forward to part 2, glycemic targets, where we will discuss and outline recommended glucose ranges and also discuss practical approaches to achieving optimal control.